actually causing the disease is it's challenging to know which is which. But if we have two targeted mutation, then the challenge is how to choose which is which. If we have a co-mutation and we don't have a medication, it's untargetable, then using Flora2, because you will need chemotherapy, and you don't know, for example, for the exon 18 in my patient, I didn't know if my exon 18, it's an uncommon mutation. I don't know if osimertinib will work. We know that they have a very poor prognosis. Then if I use Flora2, I'm going to cover both. I am using osimertinib in case if it will work, and also I use chemotherapy. Co-mutation is, we are seeing it now more and more. I guess we need to have more cases to understand, because generally speaking, so far we know that they do very poor. So it's still it's challenging, to be honest.
I agree with you totally, Samaha. I think that the issue that it wasn't addressed clearly by the Flora2, and we may consider the patient of high-risk population or the patient with high tumor burden, they may be candidate for this combination. Maybe may consider because it was not addressed on the subgroup analysis that those patients they benefit. We maybe anticipated that maybe if we are going for the oral medications plus chemotherapy will be more challenging regarding these patients. But I think we're still in the phase of understanding these types of resistance, because we know either I will address this in my case, because the patient we use for him we'll start first with, in my case, we start first with osimertinib, and the patient has a durable response. However, the patient, he had hepatic lesion, and there was no response regarding this. So it seemed that there is polyphasic, these types of mutation, and we have this element, I think, with mid exon 14. It may be the same, and I think we are still in the phase of understanding this genetic profiling and the commutations and the resistance as well. And this will drive me to another questions by Dr. Ahmed Mohammed from Egypt. He was asking about exon 18 is not responding well to osimertinib. Why we are using it? So Dr. Walid, he's
Thank
asking
you.
about L85, and you
Yeah.
presented that the hazard ratio is 1. Prof.
Yeah.
Umpik, can you please join us as well? Go ahead, تفضل.
I think that Dr. Samah, she has mentioned. The 18 is again those of a part of the disease is poor response. Those is a part of we can be used combined if the patient is fit, combine the chemotherapy using the osmartin. Nobody knows exactly. We are no, those is not a common mutation, not targetable that by osmartin. Even the hazard ratio is mentioned that's high, but again, can be combined. Sometimes we are keening that, oh, could be that's as responsible, can be combined with chemotherapy. And personally, I will go more with chemotherapy combined the osmartinib if patient is very fit patients. Again, to select those patients, we are, I think, in the learning, as you mentioned, day by day, we know more details about the lung journey of the lung cancer, especially those patients we have a resistance form and patients with a co-mutations. Again, how to be select those patients is the standard to give the every patient the Flora2. I think we have to select those patients for, as you mentioned, Dr. Mervet, high symptomatic disease, high burden of disease. I think this is the important, is very fit patient. Still, I think for a patient is not highly symptomatic, osmartinib is can be enough. When we have now, if have luxury and the lazertinib is available, again, I think we are moving forward to use TKI. Again, that's the additional for those patients.
Perfect. Prof. Umpik, do you think that it's time to introduce the lazertinib plus amivantamab in a specified group of patients? Because we know now that osimertinib alone, even with the chemotherapy, there is still unmet need for a group of patients. So if you do have it all on your shelf, which group of patient you will select for this group of patients?
Honestly, this combination, when we see a little bit about more detailed exploratory analysis of the combination of lazertinib and amivantamab, the mechanism of resistance are really less compared to osimertinib as single agent. For example, the P53, the RB1 are really less compared to the appearance and the risk of transformation that we can have. So probably there is something that where we need clearly to combine something with osimertinib. So amivantamab with the anti-MET effect, the bispecific effect, is giving us a good opportunity. For sure, I think in a young patient, really symptomatic, probably this combination will play a role. And in patients who are really don't want to have chemotherapy. So here we have a niche where we can use this combination from the beginning. But also the question that we have, what is the next after this combination? Today, probably when we are using some other, starting with osimertinib, then with Mariposa, two results, we are maybe more confident with this clear sequence that is being developed. That's why the osimertinib still maybe has a place in the first line, but this place is really not being as stronger as in the past 2 years. So the place of osimertinib single agent is not still the same as before.
I agree totally. If you allow me, we'll move to the next presentation. I will present my case. Can see my slides?
Yes.
Perfect. Thank you very much again for outstanding discussion, and it's my pleasure to share one of my cases as well. So here is my disclosure. So Mr. Muhammad is a 62 years gentleman. He was working as an engineer here in the medical city. He was a smoker since 20 years with 2 packs per day. No family history of malignancy. The condition started with repeated resistant cough and chest pain. Echo was unremarkable, and CT chest showed that the patient has right lung mass with multiple lymph nodes. You can see clearly here a significant right lung lesion with multiple lymph nodes as well. And you can see also with the PET scan, the SUV, it was 11.2 and with areas of consolidation. Patient CT-guided biopsy was carried out for him and came as adenocarcinoma grade 3, TTF1 positive, CK7 positive, and the PDL1 was 20%. TPS. NGS came as EGFR with L858R positive by NGS. And you can see by the PET scan as well, the patient has a solitary hepatic lesion. So the patient, he was from the start metastatic stage 4 disease with hepatic focal lesion. The patient was discussed on MDT. He was on a very good performance status. And so the patient, he was elected for osimertinib, and he received the treatment. After 3 months of receiving the treatment, he was not in favor to, we elected him to give him chemotherapy from the start, but he refused. And so we give him osimertinib as a single agent. In the meantime, you can see that the patient has a durable response local, almost a very good partial response, more than 80%. However, we can see that after 3 months of using osimertinib, we can see that the patient has multiple hepatic focal lesions, as you can see. And this is what we call that sometimes we can find on the primary lesion, and we also have a resistance on the hosting or the metastatic site. And we had a biopsy from the hepatic lesion and no other detected mutation. We may consider that maybe it's a primary resistance, or we do have other mutation, but it came again as L85R. And we know this type of mutation is little bit less responsive to osimertinib other than the commonest, which is exon 19. And so we elected him to add maybe to add chemotherapy for him. We added chemotherapy alimta carboplatin. And you can see that the patient, after 2 cycles of therapy, he has a flaring of the disease. You can see that has massive involvement of the liver. And the patient, after this, he was deteriorating. Even he was a good response initial, but you can see that not only this, he has bone deposit as well and massive involvement of the liver, and he became decompensated. And we sent him to best supportive care because we couldn't give him more. Of course, such kind of patients, we need to give them, we have to recognize, because I'm considering these cases like a primary resistance, even the patient he was a start. So it's start that he's receiving, or maybe we still have a subcategory from the EGFR we didn't understand well. Of course, osimertinib has a good response with this patient initial, but the patient after this, he was having flaring of his disease. I think Dr. Walid gave us a clear and a beautiful presentation about how to manage such cases. And we can see that the exon 18, it's about 1.5, which is less, and the commonest is exon 19, 46%, and the L858R, which is about the second down the road for the commonest, and followed, of course, with exon 20, which is 4.1. And of course, we do have the T790 as well. And of course, we do have now specific medications for exon 20. And we know this group of patients, they are not responding at all to osimertinib. And we have some cases, they develop flaring of the disease after receiving chemotherapy as well. And I think by introduction of amivantamab for such kind of patients, they're changing a little bit. And I think we need to understand more about this subcategories of EGFR patients. You can see that it was presented 2 years ago in the ESMO by Dr. Pazero, that of course osimertinib is the first line of treatment. However, we know that the majority of the patients, they will develop resistance to osimertinib, and we should have a backup for this patient and rebiopsy, and it was recommended by Dr. Samah and Dr. Walid as well. And the point that we need to know which type of mutation we do have, MET or HER2 or transformation. And of course, developing novel therapy is important. When we look at the ESMO guidelines, 1 year ago, you can see that for the patient with a standard of care, which is osimertinib, when they progress, either was progressing with the first or second generation, or in the third generation, we have to rebiopsy them. And it was the standard of care is the chemotherapy alone, which is platinum-based regimen. And they voted for the attendees regarding that, how they are seeing the resistance of the EGFR for these patients, for their patients. And you can see that the majority of them, they are seeing that EGFR was C797X, like Dr. Samah pointed out. And the second, it was the HER2, RET, MET, and the histologic transformation. So this is all can be applicable. And just give you a hint that we have to keep an eye on the patient response with regular radiological assessment. And of course, we know that the commonest regarding the resistance is the L858R, commonest more than the exon, however, the exon 19 as well. And this slide, it was mainly for the MET, but I wanted to show you, this is the subclassification that we do have for these genetic mutations. We do have monospecific and polyspecific. And why this? Because the monospecific, they may give the response. However, the polyspecific, you may have subcategory of the tumor, they have resistance, and you can see that it can be MET or it can be other co-mutation not detected even by the NGS. And this is explaining when the patient, he was responding initial by the primary side and has a progression local. And I think you will face it on some types of the driver mutations, because we do have in some patients, we can see response in part and not respond, and we don't know what to do for this patient, well, but we call it mixed response. But so far, we don't have a clue what to do for this patient. It will be personalized depending on the patient performance and the availability as well. And I think we clarified truly that for the osimertinib, we know that it's covering T790, and however, we do have the progression on osimertinib here. We can have MET or other like HER2 and small cell transformation. It was presented Fantastic by Dr. Walid. Regarding the FLORA-2, I will not repeat it, but just give you a hint that the combination with the chemotherapy may be added benefit. And I think we had a consensus that for a patient with a high tumor burden and good performance status, we may consider this is based on that we do have a significant PFS, which is 29 versus 19.9. And even here, the osimertinib as a control group doing better comparable to the FLORA study, which was 16.6. And there was no overall survival regarding FLORA-2, but it can be an option as well. And the second down the road, it was the Mariposa. It's a selective group of patients and selective types of medications, which is amivantamab plus lazertinib, and it was comparable with osimertinib and lazertinib. We may consider down the road to explore who is the patient can be candidate for these types of treatments, and we can see clearly it's a superior over the osimertinib as a combination, and I think the subcutaneous it will give a chance for such type of patients. And we can see even for the extracranial progression, we can say that. And the last but not least, for the patient who resistant to EGFR, patient who progressed, we do have with the combination, but still raising the question if we are giving for the patient with FLORA-2 or what to give for the patient with amivantamab plus chemotherapy for those patients. And this is considered a little bit an obstacle. But I think we can anticipate it with other types, and we can ask on this on the discussion part. And I think this was the slide regarding amivantamab for the patient with resistant EGFR. It's considered an hope, and it's the only approved medication. Thank you very much for your attention. So it's open for discussion, and I think so Prof. Umpik, do you always rebiopsy your patients? And if we are, because as Dr. Samah pointed out before, we do have a problem regarding the tissue and rebiopsy for the patient, especially for resistant patients. So, or for difficult sites like bone. So how about this part?
Honestly, we are trying to do now the Foundation One liquid, and this is a good solution, easy solution. We have the results in the next 10 days, and this is really interesting to see the tumor heterogeneity, also to have all the possible mechanism of the resistance that we can find. For sure, when we have a rapid progression, less than 1 year, we can consider it as rapid, or between 6 months and 1 year. In this case, repeating the biopsy seems really important. But also sometimes it's important to rebiopsy the lesion where we have a progression. So the new appearing lesion probably are also interesting to be rebiopsied. So we have the option of liquid biopsy, but also when we have some lesions, new lesions or progressing lesion, rebiopsying them seems important to have a complete overview of the mechanism of resistance, which is really the new challenge in the treatment of EGFR mutated adenocarcinomas of the lung.
Perfect. So in my case, you can see that the patient, he was responding initial. And also when we added the chemotherapy, the patient didn't benefit. So in such case, if we are considering that the patient, of course, he was in better and he was not decompensated, well, what will be your choice regarding such cases? Because he's not considered a secondary resistance because the patient in less than 3 months, he developed this progression. So may consider it's primary resistance more than a secondary. It's not an unusual case. So what is the options for this patient? With limited medications so far, do you consider for this patient the Mariposa 2 study or what? If we do have everything on the shelf.
This is the important point, Dr. Mirvat, of adding today the chemotherapy after osimertinib. So to combine osimertinib to chemotherapy. Are we losing a line of treatment based on Mariposa 2? So we should today, after having a progression on osimertinib, to shift directly to amivantamab and chemotherapy, or adding chemotherapy will give us a certain advantage. This is the a very important discussion that we should have, because if we add to osimertinib the chemotherapy, which is really obvious and interesting option and maybe very useful sometimes. However, are we losing the amivantamab as how we will use this bispecific antibody? Because as a single agent, it will be really complicated to use it. So this is an important discussion to have. What will be the next option when we are starting with osimertinib, adding chemotherapy, the third line treatment? We have a lot of trials today, ADCs, maybe fourth generation TKIs. However, we don't have clear approval to use in this indication.
Perfect. There is a question from Dr. Dina from Egypt. She's asking, there is no role for immune therapy in such patients. So I think she was referring to the quadri-therapy and also to the IMpower study. So what do you think?
Honestly, today there are two schools. The first school saying and confirming when we have the EGFR mutation, we should not use immunotherapy because they are immune resistant therapies. However, our immune resistant disease. However, we have some data with IMpower where we included EGFR mutated patients with positive results combining bevacizumab and atezolizumab next to chemotherapy. This is the only positive trial, but it's used in the first line setting. So there is no clear data of using this combination of immunotherapy in the further lines. Now also we have the bispecific PD-1 and anti-angiogenic drug next to chemo, showing the Harmonia trial, showing also interesting results with clear advantage of PFS. But clearly we can't say today that we should use immunotherapies in EGFR. It should be discussed case by case. If we don't have other options, maybe we can discuss it as in this patient where we use the chemotherapy, we use the osimertinib first time, maybe in the third line, what is the option? It can be an option. However, if we have other option, I will not recommend to go to immunotherapy in EGFR mutated adenocarcinomas of the lung.
Totally agree. What do you think, Dr. Walid? Do you still thinking that immune therapy has still role on EGFR resistant patients?
Thank you, Dr. Mirfat, and thank you, Prof. Hori. I think one of the important, when we are sequencing our patient treatment, we believe that's the best treatment to give in the first line setting. Everybody agree with that? How much we losing, using if there is a very benefit of selecting patient, giving the chemotherapy and target therapy like osimertinib in the FLAURA2, and that's what can be do after that. I think that's very important for us. But we believing that the good combination to start with the first line therapy, that's at the end of the day, he will looking at the end of looking for overall survival or progression-free survival. But regarding the immunotherapy, if the osimertinib is available, I think the osimertinib is giving for the second line for EGFR mutant if there is no commutations. But I have using immunotherapy in those patients when there is no osimertinib, there is no amivantamab. We're using the quadruple IMpower as a second line. I know, especially for those patients with hypertended disease, a recurrence disease, liver metastases. Especially if you are looking in details about the trial, it's like those patients with have liver metastases using atezo, bev, and chemotherapy. We know that is not that a magic, but I think that's another theory to use. We know that the targeted mutations, all of those lung cancer, ALK or EGFR, he has not responding to the immunotherapy as much we can try to avoid the immunotherapy. But when we are failed, the most important, the target therapy, and there is no commutations, I think then we can think about that after the rebiopsy, we are looking for anything to work. Could be this tumors has from the cold to hot, that's change warm. That's I think that's a part of of the using all of the options he have. But if he's failure after the target therapy of the osimertinib, the second line for me is the inventimab chemotherapy.
Perfect. I agree with you totally. Last question, because of the sake of the time, by Dr. Ahmed Al-Higeli. He was asking about your case was the PD-L1 was almost 20%. Why you didn't use immune therapy on the upfront or in the subsequent? So what do you think, Dr. Samah? Do you think that the level of expression can give us a hint? Of course, we agree that EGFR positive patients, they are not responding well to immune therapy. So do you think that level of expression can be a clue to give the patient on the subsequent therapy? Because some patients, we may find that they are negative. However, if we are like my patient, 20%, they may be a clue that they may have some response. And I think this is what Dr. Ahmed referring to. Thank you, Dr. Ahmed. This is a great question. تفضل دكتورة سما.
Thank you, دكتورة ميرفت. طبعا احنا we learn as we go. Initially, it was really challenging, but now with time, we know that EGFR and ALK, even if the PD-L1 is high, they don't respond to immunotherapy. And giving actually the targeted therapy upfront will improve patient outcome. So it's very important to use the best medication upfront, which is targeted therapy. I do agree with Prof. Hampig about the bispecific PD-L1 and VEGF. It's really promising. I think it is going to have a role in the future, and also the ADC. But for today, I believe Flora 2 and Mariposa 1 will be the best standard of care for EGFR positive patient. I do have a comment actually about what to do if the patient is progressing on osimertinib. In WCLC, we have an update about acquired resistant mechanism from Flora. And actually, the liquid biopsy from both arms showed that the acquired resistant mechanism is broadly similar. So if I have a patient progressing on osimertinib, I would prefer to go directly to second line, for example, Mariposa 2 or others, more because we know that the acquired resistant mechanism is similar between osimertinib and osimertinib plus chemo. So I would change or expose the patient to different treatment, trying to actually target as much as they can. And this is reassuring for me that adding chemotherapy to osimertinib will not add anything. You know what I mean?
Yes. Thank you. That's very beneficial comment. Thank you very much. Because of the sake of the time, we'll go to our next speaker, Dr. Ahmed Lehibi. I see that he's joining us. Thank you, Dr. Ahmed, for joining us tonight. So, Dr. Ahmed, he is known for everybody, medical oncology consultant in King Faisal Specialist Hospital in Jeddah. He will share with us one of his case presentation as well. Thank you, Dr. Ahmed, for joining, and the floor is yours.
Well, thank you very much, Dr. Mirbat. I really appreciate the kind introduction, and I really apologize deeply for being late. I enjoyed the discussion part. That was very informative. So I'd like to extend my thanks and gratitude to Dr. Mirbat and the rest of the team, the organizing committee, for inviting me to give this case presentation. So it's going to be a short presentation, but it's going to be overlapping with the bulk of the discussion that took place with the rest of the colleagues. So the case is basically about this gentleman who's a 67-year-old gentleman who has been complaining of coughing, shortness of breath, and exertion for the past few months. And when I say past few months, I mean that was in the late 2022, early 2023, associated with anorexia and weight loss. He had one episode of hemoptysis at that time. That was in February 2023, about that time, or March. That was moderate to large. He went to emergency department. He underwent CT chest, which showed large left lower lobe mass with effusion. Past medical history showed diabetes mellitus, hypertension, and ischemic heart disease. And there was some element of CKD as well. So background history, he's not allergic to any medications at home, metformin, ARP, and aspirin. The family history is not contributory. Positive smoker, actually had 50-pack year smoking history. Alcohol, he's not alcoholic. Married with good family support. He's a retired teacher. So further workup, we've done a pathology on the left lower lobe mass. and it was shown to be adenocarcinoma, moderately differentiated, and he had a TTF1 positive. The NGS and the PD-L1 were sent. He had a positive pleural effusion of malignant cells as well. Strikingly, the EGFR came back positive. It was the L858R pathogenic. So despite being a heavy smoker, he had that positive, and the PD-L1 was negative for him. So the CT chest was done in May 10th, 2023. As you can see here, it shows the left lower lobe mass. It was quite aggressive looking, infiltrating all the way to the mediastinum with pleural effusion and some pericardial effusion as well. There is no mets in the abdomen pelvis. PET scan was consistent with metastatic disease, as you can see there elsewhere, but mainly the supraclav, mediastinum, left hilar, and elsewhere. The bones were negative and the MRI brain was negative. So the case was discussed in the tumor board, and the discussion was to proceed with palliative systemic treatment in the form of osimertinib at that time. We didn't have the data about the amivantamab and lazertinib. Even if we had that, lazertinib would not be accessible to us. So definitely we went with osimertinib, looking at the overall situation, the comorbidities, the ECOG of 2 approaching 3 for this gentleman. We decided upon osimertinib, as you can imagine. So upon follow-up, he had noticed significant improvement in his initial symptoms of coughing, shortness of breath, and exertion, no more hemoptysis, and the appetite is improved quite significantly, and his ECOG as well. So restaging scans, this is the July 10th, 2023, after 3 months almost of initiating osimertinib. He had partial regression of the left lung mass. His symptoms had improved quite significantly, no recurrence of pleural effusion as well. So fast forwarding until February 2024, reminding you that in November 2023, we witnessed the release of the amivantamab studies, the Mariposa 1 and 2, and in the interim, we had the Flora 2 as well. So the CT February of 2024 showed progressive disease, unfortunately, in the left lower lobe. His symptoms recurred, and he was feeling really sick. So CT brain as well was done, which showed a left parietal lesion. It was small, but there was some kind of vasogenic edema going on at the same time. Minding you that we had frequent scans and they were quite stable since we started the osimertinib in May. So less than a year, he had recurrence with progressive disease, as you can see there. So the decision was, in light of the release of the Mariposa 2 at that time, we decided to proceed with the amivantamab plus chemotherapy. So we applied for the amivantamab and we were waiting for it. So to buy us time, we decided to start him on chemo. Mind you, we had discussed with him the possibility of getting a biopsy done, and he refused that totally. It's just we needed to know if there is any resistant mechanisms that can be targeted. But in the Mariposa 2, that was not required. So that gave us a leeway that we can go with amivantamab chemotherapy. So she had received 3 cycles of the treatment in the form of chemotherapy, carboplatin, pemetrexed, and then amivantamab arrived, and he was started on chemo and amivantamab for 2 more cycles. Then we stopped chemotherapy, the maintenance pemetrexed, as well as the carboplatin, mainly because of the severe AKI on CKD with significant reduction in his EGFR. It was quite worrisome for us to continue with pemetrexed. He has already been on amivantamab, so we carried on with the amivantamab in between. He had stable disease since he's been on it. He completed 7 cycles altogether of amivantamab. Last cycle was given in January 12th, 2025, only this month. Unfortunately, the CT chest had been stable for the past little while, maybe some element of minor progression, but now we have significant progression of his disease. Unfortunately, I wasn't able to pull up his scan here. It was obliterating the left lung, significant collapse, significant pleural effusion, and pericardial effusion as well. So we decided to make him as declare him as DNAR and transfer him to palliative care for full supportive measures. So the main takeaway message of this particular case, and it's quite challenging because definitely we're going to run into such cases like that. So the addition of amivantamab to me amongst the artillery for treatment of EGFR positive metastatic non-small cell lung cancer, mainly the common mutations along with the exon 20, had improved the responses, PFS and OS, especially in the second line setting. Mind you, the first line setting is quite intriguing to start patients on amivantamab and lazertinib. The use of amivantamab was quite tolerable for my patient. There are absolutely no issues when it comes to pre-medications. The infusion-related reactions were non-existent. He received almost 8 cycles of amivantamab, as I said. We have to be very vigilant that we need to start these patients on enoxaparin once we commence them on chemotherapy with amivantamab as a prophylactic dose. And we always need to consider the possibility of a biopsy to lay that down as an option for the patient, just to be more informative in our decision-making process. And with that, I conclude my presentation. And thank you very much for your kind attention.
Thank you very much, Dr. Ahmed, for sharing your experience and also sharing your case. So I think you hit a very important element. I think we all a little bit vigilant about the infusion reaction and also the manifestations with amivantamab, and it can be one of the barriers, especially most of the patients with lung cancer. They receive as a first line, they may fail, they may not be candid. So in your experience, you give the patient 7 cycles of amivantamab, and you pointed that with the good medications, pre-medications regarding the infusion, it went very well. So how you did this perform this and can you please illustrate more about what you did exactly, and also your nursing team as well?
Yeah, I remember those days. So basically, what we've done, and we didn't have that protocol initiated electronically, so we have or automated. So we have to put it down, like we had to write it down, like in the old days when we wrote down the chemotherapy. So clearly write in the diphenhydramine, the doses, basically to be initiated 1 to 2 hours before, the dexamethasone doses to be initiated properly as well, and most importantly is basically to give them that space before we initiate the amivantamab. And we had written down the rate of the amivantamab basically at initiating dose, and how to reduce it should you face any reaction. Stop everything, give more pre-medications, the diphenhydramine, the dexamethasone, or the hydrocort if you have it available there. Give more fluids and initiate the rate at 50% reduction than the previous one, and monitor for an hour. If everything's okay, then reinitiate back to the previous rate. So we definitely had no issues so far. So it is the basically one of those things that we have to be very vigilant of the pre-medications and how to initiate them. Is the usual medications that we give, the dexamethasone, the diphenhydramine, and basically upon reaction, give more of those medication, not dose reduce, but lower down the rate and go from there. No issues so far, alhamdulillah.
How about the skin manifestations? Do you face any?
So
Or it-
far,
it was-
for my patients, I haven't seen any, to be honest. None of those reactions at all. None of the skin manifestations, none of the infusion-related reactions. The DVT, definitely we had given them, so I haven't noticed that. So we've given them the prophylactic enoxaparin. It was all in all very tolerable. And again, he like received almost 5 cycles as single agent amivantamab because of the severe AKI, stable disease, good responses similar to the chrysalis, so there were no issues with him until recently.
There is a question from Dr. Muhammad El Arabi. He's asking for the patient with MET amplification, what you will do for them? Also amivantamab, or you will give a specific medication?
So it's an excellent question. So basically, we all know that the amivantamab is the bispecific monoclonal antibody that would target both the MIT-14 as well as the EGFR. I think this is the natural approach of how we go by these patients, basically just continue with amivantamab because it should tackle it. That being said, we know that there's other studies that looked at the use of tepotinib with osimertinib. These studies are phase 2 studies, so none of them is a phase 3 study like this one. So I would always go by the phase 3 study, so it's more reliable, more applicable in practice. So even if there's a MIT-14, we go with amivantamab chemotherapy. Mind you, the beauty about the Mariposa 2 is that they did not make the biopsy as a mandatory thing. So we always have a leeway to just go by in an automated way, just to go by basically the amivantamab chemotherapy.
Okay. I think I agree with you totally, but I think that possibility of biopsy is important. And of course, as you
Absolutely.
mentioned,
Absolutely.
that but still we don't have a clear input, like you mentioned, that what to do for the patient with MET amplification, HER2 positive patient, or even for the small cell. So we may consider that those patients is a group of patients we identified, the patient with non-identifiable may go for the treatment. And if we are unable to go for a biopsy, this means consider the empirical treatment. As you pointed, it was not mandatory. Yeah.
Absolutely. Absolutely.
Perfect. Thank you very much, Dr. Ahmed. Please
Thank you.
join us on the asking the cases for opinion. Can you please go for the polls? So I would like to thank all the attendees who's asking for the for cases. Can you just hold it for a second, please? Because I have to present the case first. So Dr. Ahmed Al Jassim from Qatar, he's asking for one of his cases. So he is a 77-year-old gentleman known to have smoker, BPH, also he has bone deposit as well. The patient was diagnosed with lung cancer, adenocarcinoma, presented to pulmonology with shortness of breath. Bone-guided biopsy came as adenocarcinoma, so he's a stage 4 disease, lung lesion, and also bone deposit as well. And we can see that on the staging, the PET scan showed that there is a left loop lung mass surrounded with low metabolic activity and consolidation, and the patient has multiple metastatic osseous lesions. The patient, he was in a good performance status. The histology, he had a biopsy also from the bone and came as poorly differentiated malignant neoplasmus necrosis. The NGS, EGFR positive, exon 20. It seems that this is the night of L858R deletion, and also came with P53 positive and the PDL1 30%. So he is asking how to treat this patient. So what is the best approach? Osimertinib, single agent, osimertinib plus chemotherapy, IO plus chemotherapy, or of course amivantamab or plus lazertinib. Can you please put the polls, please?
There's no amivantamab lazertinib, Dr. Mirbat.
Yeah,
There's
I know, but just I added.
Okay.
Yeah, he would just only put this as a we put this as a choices. So can you please put the polls? I cannot see it here. Okay, so we can start the voting by the panel because I couldn't see the polls by the attendees. We wanted to make them voting first. Guys, we can make them voting or what? Can you put the polls? Ms. Wafa?
Ready done يا دكتور.
Already done? Can I see?
Yes.
I didn't see the results. Okay, so I will
Just a minute.
okay, I will. Okay. So we put the polls asking the attendees about their opinion, what to do for the case. So about 36% go for the osimertinib single agent, and 36% as well with osimertinib. I think it was the second choice with chemotherapy. IO with chemotherapy, it was 29%. I am not sure about this part, but thank you very much for your voting. So, Dr. Ahmed, what do you think is the best approach for this case?
Okay, thank you very much, Dr. Mirbat. That was an excellent case. Definitely one of the things that we always see in our clinic is the presence of the PD-L1, the EGFR, the L858R. So basically, just to lay out down the main roles that we have to play down by with such cases. In any driver's mutations, basically, we only give the targetable agent. We refer away from immunotherapy because definitely they do not work, period. In none of the studies basically that had looked at the immunotherapy when the EGFR or ALK or ROS1 even, I would say, they do not exert the same action that they would do in otherwise drivers mutation negative patients. So in this particular case, the main issues that we are facing is the L858R. So osimertinib is not the best option as a single agent. We all know that. The hazard ratio crosses the 1 in the FLORA study. So the other issue that is problematic is the presence of the P53 positivity. So this carries a higher risk of possible transformation. Even if the RB1 was possible, that is like positive there, then that's basically a double whammy. So the possibility of small cell lung cancer transformation is quite higher, even in that case. So in this particular situation, I would go with the FLORA2 osimertinib chemotherapy. If we have the amivantamab, lazertinib, that would be the best option to me, I would think. Keeping in mind, the PDL1, again, to reiterate, is not the best marker, even as a prediction to the response to immunotherapy. So the idea of immunotherapy in drivers mutation patients is non-existent. We should not proceed with that at all, basically, in all lines, to me, basically. I'm not convinced with any of the studies, especially with the quadruplet. They looked at patients who had received osimertinib or alectinib or basically crizotinib before, and it was done as a subgroup analysis. It was not convincing. It was reiterated again in first-line setting. In the Atlas study, if I'm not mistaken, it was negative. So there's a lot of studies that were negative and only query murky positive studies. Thank you.
Great comment. Thank you, Dr. Ahmed. So, Prof. Umpik, can you comment on the best approach on this patient?
Yes, I think the best approach, as mentioned by Dr. Ahmed, is the combination of lazertinib, amivantamab, and we have the exploratory analysis of mutational profile after using and the percentage of TP53. So I think when we have the TP53, this combination will be the best option compared to a single agent osimertinib. For sure, the IO, there is no place independent of PDL1 because when we have the EGFR is driving PDL1, no place for it.
Perfect. I agree with you totally. So we'll go for the second case by Dr. Muhammad Al-Arabi from Tabuk. 60 from Saudi Arabia, 66 years gentleman, performance 2 to 3, diabetes mellitus type 2, hypertension, and CKD. He's a cardiac patient as well. Patient presented with massive effusion, precardial and pleural effusion, hepatic focal lesion, and biopsy came as adenocarcinoma grade 3. PDL1 10%, NGS PRAF positive, patient is on dialysis. So he is asking what is the best approach for this patient. So here is the choices. IO plus chemotherapy, chemotherapy alone, IO alone, best supportive care. What do you think? Can you please vote? Are we done with the voting, Ms. Wafat?
Yes, doctor.
Okay, can you please show the results?
Okay.
So between now and then, we do have this critical case. So 47% voted with IO plus chemotherapy and 29% chemotherapy alone, IO alone, about 13% best supportive care. So I think this is one of the cases we are facing on the clinic with critical patient PRAF positive. And of course, for the PRAF positive patient, we are going for the IO as an upfront plus chemotherapy. However, the patient with his critical condition, performance 3, what is the best choice? So, Dr. Samah, can you give us your thoughts regarding what to do for this case?
Yeah, so it's this is a very common scenario that we see in the clinic, and it's
Yes.
really challenging. His equal, if we go by actually textbook, best supportive care is the answer. However, if the patient, for example, smoking history, if he's a heavy smoker, ex-smoker, and then I might consider immunotherapy single agent. I don't see a combination in this case. It will be too toxic for the patient. He's really borderline. The other thing is we don't know about the BRAF, if it's a V600E or no. This is another thing.
I think he meant the PRF V600 as it wasn't mentioned, but I think it was this one. But I agree with you totally that IO therapy in such cases it can be the option. I will vote like you said. IO plus chemotherapy, it will be toxic, especially the patient on dialysis and also CKD cardiac patient, massive effusion. I think we have to be cautious. It can be single agent versus peer supportive care. What do you think, Dr. Walid?
I think very interesting case, unfortunately. Yeah, and that is a reality of our life when we are seeing these patients. But I think with these patients, it's comorbid cardiac, and he has old age on dialysis. Our aim, our aim is all is palliative intent. I think I totally agree with Dr. Samah and with you. I mean, to have a realistic with bromostatus 3, that's by book is best supportive care. That's the first choice. Unless he show BDL1 more than 50 or 90, and then we'll say we'll give him the chance and we'll give the immunotherapy. But we know that immunotherapy alone in less than this is only 10%. This is the options, but for eco-process 3, I think by book, by evidence to support is the best supportive care. But if it's for a certain conditions, I think we can utilize. But for these patients, comorbid, dialyzed, ECOG 3, if it's ECOG 3 is clearly that's ECOG 3 because of not only the disease, the comorbid, I think that's the best supportive care.
Agree, totally. Last comment by Prof. Khoury, and what do you think, peer supportive care versus single agent?
No, I will go for the best supportive care in this case because the advantage of using single agent IO is really small.
Perfect, I agree totally. And thank you very much for asking to present your cases, and it's always our pleasure. And it's my pleasure to introduce our next speaker, Prof. Umpik Khoury. He is known for everybody, and he is one of the dearest colleague and one of the experts in the field. Prof. Khoury is a professor in Hotel de France University and St. Joseph University in Beirut. He will give us the keynote lecture today about the overcoming resistance, and also he will share one of his cases. Thank you very much, Prof. Umpik, for joining tonight and enrich our discussion as well. The floor is yours. Thank you.
Thank you very much, Dr. Mirva. Thank you for organizing this series of tumor board, thoracic tumor board, that you are rendering the level to next level in our region in thoracic oncology. Thank you very, very much for inviting us and for this very rich discussion that we had tonight and every time we are doing this thoracic tumor board. Thank you for being such a great leader for us all. So in the next 20 minutes, I'll start by presenting a case and discussing the overcoming resistance to osimertinib, the constant battle. Let's start with the case. Those are my disclosures. It's a 43 years old woman, non-smoker, married, presented with intensive back pain in June 2024. A lumbar MRI, she was evaluated first by an orthopedic surgeon, presence of bone metastasis. A total body CT scan was done, showing a cluster of large paramediastinal adenopathies, the largest measuring 3.5 times 3.7, associated with peribronchovascular lymphadenopathies. Also, we had about 15 secondary liver nodules considered as metastatic lesions. Also, multiple lytic bone lesions. The pathology findings of CT-guided biopsy of the right iliac crest showed a primary pulmonary adenocarcinoma. The immunohistochemistry confirmed that the PD-L1 was negative the ALK was negative, the ROS was negative, and the RT-PCR showed EGFR exon 19 deletion. The PET scan confirmed the extension of the disease, multiple metastatic lung and liver nodules, and bone metastasis. Also, a brain MRI showed cerebellar lesions. The patient in July 2024 started on osimertinib. In August 2024, a PET scan of evaluation after 3 months showed major response to treatment. And we had an exceptional clinical amelioration. The patient who presented with an important lower back pain was completely asymptomatic. And you can see here how the lesion that was 4.8 centimeter become in 3 months 3.6, and many of the symptoms were revealed. Also, in October 2024, 3 months later, another PET scan done show skeletal metastatic disease was relatively stable, but we have mild reappearance of activity associated with the right basilar lung mass. The same treatment was also continued till December 2024, when we have a progression of the lung lesion with major progression of metastatic bone disease that was considered as symptomatic. At that point, since we had 7 months of treatment on osimertinib, we decided it was considered short period of response. Foundation 1 CDX was done, showing and confirming that we had the EGFR exon 19 deletion, but also we had the appearance of TP53 alteration. So this one was one of the explanation why we had this rapid progression of the disease. So in January 2025, the patient started with the combination of carboplatin pemetrexed with the first dose of amivantamab, divided the first one in 2 days, and injection of zoledronic acid. So as you can see, we started in June 2024 with symptomatic patient, rapid response after 3 months. We have appearance of some stigma of recurrence few months later, till we had, after 7 months, a progression of the disease. The foundation 1 didn't show new alteration, despite the TP53 that was positive, and the patient started a second-line treatment with amivantamab, carboplatin, pemetrexed, and zoledronic acid. 2 interesting questions. Will you be treating this patient with osimertinib as first line in 2025? And the second question, what will be your other possible treatment option in 2025 after osimertinib or after another possible first-line treatment? Let's discuss the possible mechanism of overcoming the resistance to osimertinib, which is a constant battle. Many of my colleagues presented how the landscape of the treatment of non-small cell lung cancer and mainly the adenocarcinoma is shifting. Today we are treating based on genetic alteration. And the 2 major EGFR alteration are the exon 19 deletion and the L858R point mutation. They represent together the most frequent EGFR mutation, around 85%, but also we have some rare mutation and also the group of exon 20 insertion that has dedicated therapeutic agent today. The majority of the EGFR mutated patients are considered never smoker or previous smoker, 22%, only 8% are current smoker. The percentage of EGFR mutation in our region, in our last publication, was around 15.7% in the Arab world, compared to 47% in the Asian population. Also, our friend and colleague from Morocco, Zainab Ben Ibrahim, published in 2018 another review paper evaluating the percentage of EGFR in our region, and it was considered around 20%. And we can say that in our Arab world is between 15 and 20%, and it can vary between the different countries. We published in 2023 this review in Cancer Treatment Reviews, the acquired resistant mechanism to osimertinib, the constant battle, in collaboration with Gustave Roussy in France. And the concept behind it was the new challenge of resistance for anti-EGFR. The first challenge was resolved. The first and second generation EGFR TKI developed resistance T790M, and it was overcome by osimertinib. However, the new challenge is how to overcome the resistance to osimertinib, the third generation EGFR TKI. It's a busy slide, but the message is clear. We should target the EGFR dependent pathway and the EGFR independent pathway, and you can see the huge number of mechanisms of resistance to osimertinib. Mainly, we can talk about MET amplification, MET mutation, HER2 mutation, HER2 amplification, FGFR, AXL overexpression. So it's important to build strategy to overcome this resistance. So we have two big strategies. The first one, using new drugs to combat EGFR TKI resistance in the second line, single agent strategy using novel ADCs or fourth generation EGFR TKIs, combination strategies with chemo IO anti-angiogenic drugs, double TKI, bispecific antibodies and chemotherapy, and completely different strategy on changing and manipulating the first-line treatment to combat EGFR TKI resistance by adding to the third generation, maybe chemotherapy, anti-angiogenic agent, and bispecific antibodies. So the concept of combating resistance on TKI, on osimertinib, it's on target by using fourth generation EGFR, off target by using combination of anti-angiogenic and anti-PD-1 therapies, combining on and off target therapy using anti-EGFR, anti-MEG, anti-EGFR, anti-MET chemotherapy, or using antibody drug conjugate targeting HER3, MET, TROP2, targeting those tumor-associated antigen. Let's start with the last part, the novel antibody drug conjugate. We have the HER2 and HER3 ADCs, the patritumab deruxtecan. We have the MET ADCs, the telisotuzumab vedotin, and the TROP2, which is now showing a lot of interest in bladder and in breast cancer also, the datopotamab deruxtecan targeting the TROP2. And those three trials, HERTHENA Lung 1, Luminosity, TROPSION Lung 1, who included some of them EGFR, the patritumab deruxtecan was only EGFR mutation, the other included EGFR mutated patient, among others, showed overall response rate around 30%, which is really promising agents in the management of EGFR mutated adenocarcinoma. The second way or modality is working on target by inhibiting the EGFR using fourth generation EGFR TKI. Why the fourth generation? Because the majority of on-target resistance is based on the cysteine to serine mutation in EGFR, the C797S, which are conferring the resistance. And overcoming this mutation will lead to offer to our patients better outcomes. Also, when we are talking about off-target inhibition, we are talking about combination of anti-angiogenic and anti-PD-1, PD-L1 agent. or using on and off target by using the combination of anti-EGFR and MET TKIs or anti-EGFR plus chemotherapy next to anti-MET bispecific monoclonal antibodies. The question was asked before about the place of immune checkpoint inhibitor, and clearly the Empower is the only one showing interesting result in this subcategory of EGFR mutated patients where the combination of atezolizumab and bevacizumab and chemotherapy showed interesting results. But also we have in the pipeline this bispecific antibody combining anti-angiogenic and anti-PD-1, the ivonescimab combined to doublet chemotherapy, who is showing in Harmonia trial very interesting result. So this combination is not dead, but it's difficult to have a resurrection of this combination. Also, it's interesting to see this biomarker-driven study for each resistant mechanism of after osimertinib, we give different treatment to counteract this mechanism of resistance. The first arm is the MET alteration, where they combine osimertinib and an anti-MET, the savolitinib, and when it's EGFR mutated and we have MET-driven locally advanced or metastatic non-small cell lung cancer, adding this anti-MET, the savolitinib, to the anti-EGFR and osimertinib was considered one of the options, with the primary endpoint being the overall response rate. And also when we have more expression of MET in immunohistochemistry and in fish, we can reach around 49%. So in well-selected patients, this drug in combination with osimertinib can be very interesting. So when we have this overexpression of MET. Finally, all those were experimental. Which is really approved is only the Mariposa trial, combining the bispecific antibody targeting the EGFR and targeting the MET next to chemotherapy after osimertinib, after progression on osimertinib. And this Mariposa 2 trial, with its second interim analysis, showed very interesting results on overall survival. So the key eligibility criteria in this study is documented EGFR, the most frequent mutation, progressing after osimertinib as monotherapy, as most recent line, with good performance stated, 3-arm in this study, amivantamab, lazertinib, chemotherapy, and amivantamab chemotherapy. The two last lines, chemo versus amivantamab and chemotherapy, showed very interesting results on overall survival. We have 17.7 versus 15.3, with the advantage of 2.5 months in overall survival, with hazard ratio of 0.73 and with the significant p-value. And at 18 months, landmark for overall survival was 50% for amivantamab chemotherapy versus 40% for chemotherapy all alone. Also, we can see that we have 27% reduction in the risk of symptomatic progression with amivantamab chemotherapy versus chemotherapy. Time to symptomatic progression was 16 months with ami chemo versus 11.8 for chemotherapy. Also, the time to treatment discontinuation for amivantamab chemotherapy was 5-fold more patients remained on treatment at 18 months versus chemotherapy. So that was how to overcome the resistance in second line after starting the osimertinib in first line. The second type of strategies is to overcome this resistance before it appears by working on the first line and by manipulating the first line treatment with combination strategy. TKI plus anti-angiogenic agents, TKI plus bispecific antibody, and TKI plus chemotherapy. The RELACE trial was one of the first who showed very interesting results with ramucirumab and erlotinib, compared to erlotinib, the first generation TKI, and we had an advantage of PFS of around 8 months when adding this anti-angiogenic drug to the erlotinib. And also we have very interesting overall response rate. So this was very promising study. In ESMO 2023, the same exercise this time was done with osimertinib plus ramucirumab. We have contradictory outcomes between two trials. One was negative, the other one was considered positive. So we are not sure of the level of evidence of using this combination of osimertinib and ramucirumab in the first-line setting. However, we should keep in mind that adding anti-angiogenic to our TKI may be an interesting option. Also, the FLORA2 that was also discussed before showed an advantage in progression-free survival. For the first time, the median was around 25, median overall survival, progression-free survival was around 25 months versus 16.7 months with osimertinib monotherapy, but that was of high cost of toxicity, mainly in the hematologic toxicity, which was 71 versus 24. And finally, the Mariposa trial, where the combination of amivantamab and lazertinib showed an interesting progression-free survival of 23.7 months versus 16.6 months on osimertinib. So we had these three possibilities of adding chemo, adding anti-angiogenic drugs, or adding the amivantamab next to those medication, the bispecific antibody, next to the third generation TKIs in the management of EGFR mutated adenocarcinomas. According to the NCCN guidelines, still the osimertinib is considered the preferred category 1 regimen, despite all we discussed about that this osimertinib alone is losing territory against the other combination. Other recommended also, the category 1, we have the amivantamab lazertinib, and also we have, based on FLORA2 in non-squamous, the osimertinib, pemetrexed, and the platinum agent. When we have the progression and we have multiple lesion progression, the only one approved after osimertinib, according to the NCCN guidelines, remain the combination of amivantamab plus carboplatin and pemetrexed. So thank you very much. This was the new era also in Lebanon, where we are rebuilding strong relation between Lebanon and Saudi Arabia at multiple levels. Thank you.
Thank you very much, Prof. Fafouri. That was excellent talk and sharing case and also great update. Because of the time, we'll just only took 2 questions from first, if any of the panelists today want us to ask Prof. Fafouri about his presentation. Okay, so I will, there's 2 questions from the attendees. Dr. Iman from Morocco, she's asking how to identify the primary resistance in such cases. I think she meant by time or by how we can say that the patient has a primary resistance. So what do you think?
I think we should start doing NGS systematically, large panels at upfront, not only waiting the progression. And then we can compare. Maybe the ideal word will be to do NGS on the tissue, NGS on liquid upfront, and also at progression, we can do the liquid to see the different abnormalities and the different mechanism of resistance that we are developing. And this is really an important point because, for example, in my case, unfortunately, I did only the evaluation after progression by foundation 1. So the main question was, this TP53 found in this foundation was present at the beginning? It was a primary resistance or it appeared after the treatment? So that's why the ideal world, it's costly. We know that the third party will be, and the government will not be very motivated to cover all this testing. But for science and to offer the best for our patient, it will be really interesting to evaluate the abnormalities that we can have, the mutation that we can have, as we do an antibiogram to see all the genetic abnormalities that we can have, mainly in this type of mutations.
Next question by Dr. Ahmed Al Jassim from Qatar. He's asking about the subsequent therapy with amivantamab and lazertinib, and there is any rule now for ADCs or just only future direction?
Today, we don't have a clear approval of ADC, but they are in the pipeline. And for sure, we will see very interesting results. And also in EGFR mutated patient, maybe in the third line to start. And this will be really interesting. Maybe the ADC targeting the MET will play an important role. What we can offer after lazertinib and amivantamab, I think the chemotherapy will be the next option in this sequence of treatment. Now, our colleague also was mentioning we should use with it the IO and the anti-angiogenic, use the Empower trial, or only use in second line because the Empower was mainly in the first line, or we use only chemotherapy. This is also an important question. We should see how is the coverage, the patient will pay it, who will pay it. It can be sometimes beneficial, but also I'm not very encouraged to use for the quadruplet. I will go maybe for double agent chemotherapy.
Perfect. Thank you again, Prof. Khoury, for excellent talk and discussion as well. And it's my pleasure to go for the Stellite Symposium. And the Stellite Symposium is sponsored by our colleague and partner from Johnson tonight. And it's my pleasure to introduce the chair of the Stellite Symposium, Dr. Abdullah Al-Twergi. Dr. Abdullah, he is one of the key leaders in lung and breast in Saudi Arabia. He will chair the Stellite Symposium. Dr. Abdullah is medical oncology consultant in King Fahd Medical City in Riyadh. Dr. Abdullah, thank you very much for joining, and the floor is yours. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much, Dr. Mirfat, for keeping this tumor board running. And I was in the background. I was enjoying the discussion. I really enjoyed the discussion of all our speakers today. It's really nice to share those experiences, and especially the difficult cases that has been discussed earlier. So finishing up with this satellite symposium, I would like to thank Jansen, and I think I would like to welcome back Dr. Samah Raheli. Dr. Samah is a medical oncologist in National Guard Hospital, Jeddah. She will go through the data that we have with the Mariposa 2, because now this is becoming a standard of care post osimertinib, and it's really good to share the data and just see the experience and how much the data could be applied to our patient population nowadays. And with this, I would like to welcome you, Dr. Samah. You can go ahead.
Assalamu alaikum. Thank you, Dr. Abdullah. Thank you, Johnson. So tonight I was asked to talk about Mariposa 2. So the story of EGFR after osimertinib maybe was disappointing until recently. We didn't have a lot of treatment option in terms of what to do after the progression of on osimertinib. And yes, we have a chemotherapy as a second line, which was the standard of care. However, the outcome was really poor, and it was an area of unmet need. And then today we have new options in the first line and in the second line. We are seeing very promising ongoing trials, ADCs, immunotherapy plus VEGF, anti-VEGF. So I think in the near future, we will have more and more treatment options, and hopefully with more treatment options, this will improve our patient outcome and increase survival. As Prof. Hampi showed us that in the NCCN guidelines today, after progression on osimertinib, if the patient did not receive amivantamab in the first line as in Mariposa 1, then the preferred category 1 option is to use carboplatin pemetrexed plus amivantamab as per the Mariposa 2. When we go over the resistant to first-line osimertinib, it was well covered by my colleague. However, we do know that we have around 40 to 50% of unknown. So yes, we are having a better understanding with time, yet the unknown or what is happening around 40 to 50%, we really don't know what is the cause of acquired resistant mechanism. MET amplification is very important because it's around 7 to 15%. It can be an on-target or off-target, and also it can be a transformation to small cell. When we look at how to target, it's the acquired resistant mechanism. It's either on-target, off-target, combined, on and off, or targeting tumor-associated antigens. When we talk about Mariposa, we're talking about combining on and off target inhibition. So by targeting EGFR and MET monoclonal antibody with chemotherapy as in Mariposa 2. Mariposa 2 was the result initially presented in ESMO of 2023. It is a phase 3 global randomized control trial. We do know that the resistant mechanism after osimertinib are diverse and polyclonal. EGFR and MET alteration may account for 25 to 50% of the resistance, and the outcome with platinum-based chemotherapy is really poor. From the phase 1 data, Chrysalis, we know that amivantamab chemotherapy or amivantamab lazuretinib chemotherapy did show a very promising result, for which we are now seeing it in Mariposa 2. The other point is lazuretinib is a highly selective CNS penetrant third-generation EGFR tyrosine kinase inhibitor. When we look at the study design, so the key eligibility criteria is locally advanced or metastatic non-small cell lung cancer, documented EGFR exon 19 deletion or L858R, progressed on or after osimertinib monotherapy with excellent performance status 0 or 1. Stable brain metastases were allowed. Radiation or definitive therapy was not required. The beauty about Mariposa, either 1 or 2, they did have a very frequent serial brain MRIs were frequently or required for all patients. Patients were randomized 2 to 1, 3 arms, amivantamab lazuretinib chemo versus chemotherapy versus amivantamab chemotherapy. And the primary endpoint was PFS for the quadruple versus chemo versus the triplet versus chemo. They did have to modify the protocol. During the study, the IDMC identified increased hematologic toxicity in the amivantamab lazuretinib chemo, for which they added now the lazuretinib after finishing the chemotherapy, and we will have a future analysis to evaluate the impact of this modification. When we look at the baseline disease characteristics, well balanced between the arms. If we look at the primary endpoint, progression-free survival, for the quadruple, hazard ratio was 0.44, for the triplet, 0.48, and amivantamab chemotherapy decreased the risk of progression or death by 52%, and if adding lazuretinib, it was decreased by 56%. When we look at the subgroup analysis, it was supporting the use of combination compared to chemotherapy. And if we actually look at the quadruple by adding lazuretinib, it was also support the use of the combination versus chemotherapy in all subgroup. When we look at the overall response rate, it was 63 for amivantamab lazuretinib chemo versus 64 for amivantamab chemo, versus 36% for chemotherapy. So it's almost doubled if we add more medication compared to chemotherapy. And the duration of response was 5.6 for chemotherapy versus 6.9 for amivantamab chemo versus 9.4 for the quadruple. When we look at intracranial progression-free survival, it was interestingly the hazard ratio 0.55 for amivantamab chemo versus chemo, and 0.58 for amivantamab lazuretinib chemo versus chemotherapy. When we look at intracranial progression-free survival, if the patient had a history of brain metastasis and no prior radiation therapy, hazard ratio for amivantamab chemo was 0.36 versus 0.44 if we add lazertinib. When we look at the median treatment duration, it was of course longer for the amivantamab containing arm versus chemotherapy. However, this will come at cost of toxicity. The discontinuation of all agents due to treatment-related adverse event was 2% in the chemotherapy arm versus 8% for amivantamab chemotherapy versus 10% for amivantamab, lazertinib, and chemotherapy. When we look at the safety profile, if we add more medication, of course, it will come at cost of toxicity. For drugs, there is a 92% grade of more than 3 or equal to 3 treatment-related adverse event. If we're talking about 3 medication, it's 72%. If we're talking about chemotherapy, then we are talking about in the range of 40%. For the amivantamab lazertinib chemotherapy, the interruption was 77%, dose reduction was 65%, and discontinuation was 34%. If we look at actually associated with EGFR inhibition, it was in the range of 40% in the amivantamab chemotherapy and increased with the amivantamab lazertinib chemotherapy to sometimes up to 50%. If we look at associated with chemotherapy, it was also higher with the combination compared to chemotherapy arm. Very important to highlight the risk of VTE. It was 10% for the triplet versus 22% for the quadruple. And the question is, adding lazertinib will come at cost of significant toxicity. Do we need to use this arm for all, or do we just go with amivantamab chemotherapy? The other thing is we'll know and learn with more data to come about the modification of the protocol. If we add lazertinib after chemotherapy, is this going to improve toxicity profile? The conclusion from the presentation was amivantamab chemotherapy and amivantamab lazertinib chemo are the first regimen to demonstrate improved PFS versus chemotherapy in the EGFR mutated advanced non-small cell lung cancer after disease progression on osimertinib. Then in the last ESMO, Dr. Sanjay Popat presented the second interim overall survival from MARIPOSA-2, focusing on this presentation on the amivantamab chemotherapy versus chemotherapy alone. And the overall survival hazard ratio is 0.73. Amivantamab chemo continues to demonstrate a clear and improving OS trend versus chemotherapy. At 18 months, it was 50 versus 40% in the chemotherapy arm. When you look at the time to symptomatic progression, hazard ratio 0.73, again, was significantly improved with the amivantamab chemotherapy versus chemotherapy. If we look at time to treatment discontinuation, hazard ratio is 0.42. The median time to treatment discontinuation is 10 versus 4 months, again, favoring the combination over the chemotherapy alone. Then if we look at time to subsequent therapy, was also significantly prolonged with amivantamab chemotherapy versus chemotherapy. Amivantamab chemotherapy median time to subsequent therapy is 12 months versus 6 months for chemotherapy, hazard ratio 0.51. Then if we look at the first subsequent therapy, fewer patients in the amivantamab chemotherapy arm had disease progression, around 68% versus 83% in the chemotherapy arm. If we look at what is the commonest medication that was used after osimertinib, we can see that chemotherapy and then maybe TKIs combination. PFS after the first subsequent therapy, we are talking here about PFS2, was significantly prolonged with amivantamab chemo versus chemotherapy at a rate of 39% in the combination versus 27% for the chemo. The median PFS2 was 16 months versus 11 with the hazard ratio of 0.64. Then the conclusion from MARIPOSA-2 from ESMO 2024, that at the second interim analysis, median follow-up is 18 months. Data continued to favor amivantamab chemo over chemotherapy with a promising OS trend in the post-osimertinib setting. And then also it did show an improvement in the time to symptomatic progression, time to treatment discontinuation, and time to subsequent therapy, and also PFS2. And longer MARIPOSA-2 follow-up results confirm the superior outcome of amivantamab chemo versus chemotherapy in EGFR mutant advanced non-small cell lung cancer after disease progression on osimertinib. In September of 2024, FDA approves the regimen, the Mariposa 2, and also they had an EMA approval. The next question is actually if we have the approval of Paloma, the use of amivantamab as subcutaneous, then one of the very concerning toxicity is the allergic reaction or infusion-related adverse event. Then with the subcutaneous, this is maybe actually improve our patient outcome when we consider such regimen. However, we do know that in the first-line setting, we have Mariposa as a first-line combination lazertinib and amivantamab. It is also an approved FDA regimen. We do have this month a press release that the median overall survival improvement expected to exceed 1 year compared to osimertinib. Then if this is actually showing an overall survival benefit, I would think that this would be the preferred first-line treatment option. Then what will happen to Mariposa 2? We have a lot of treatment option now in the first-line setting. We have Flora, we have Flora 2, we have Mariposa 1. And then I guess upon progression, we have Mariposa 2 if we did not use Mariposa 1 in the first-line setting. We have, as mentioned by my previous colleagues, a lot of ongoing promising data such as ADCs. So it is an interesting time for EGFR treatment because in the past we had osimertinib and then nothing after that. And now we have more treatment options. And with this, I conclude my presentation. Thank you.
Thank you so much, Dr. Samah. It's, I really enjoy your talk. It's, it seems that single agent osimertinib is being now challenged, definitely. And I think the data that are coming in the first line probably will push more to combo rather than a single. But let's focus on the Mariposa 2, which I would say it's maybe it set the ground to have more experience on amivantamab before we start using this in a more kind of frontline setting, because in a frontline setting, you expect this treatment will be much longer than what we are seeing in the second line setting, especially post osimertinib. And I was looking on the interim analysis if we come across or if they did some sort of biomarker analysis, because it seemed things are easier in the past where we start with first, second generation, then we knew there's T790, then we go to osimertinib. But now it has been discussed earlier, we do have very quite complex biology post osimertinib, and with different sort of alteration that may be EGFR MET dependent or independent in both. So it makes sense that to use chemo because and bispecific antibody in order to target all of those. But I was wondering if they have done any biomarker analysis or kind of try to tease out who are those who benefit the most from the combo among those patients who progress on osimertinib. They didn't show any data on that.
Yeah, I am not honestly aware about any data regarding Mariposa 2. However, we know from Mariposa 1 that we do see more MET mechanism or acquired resistant mechanism and less EGFR, and the complexity of commutation is less compared to the use of osimertinib in the first line. But if as a second line, no, and as Dr. Lehebi was mentioning, the beauty about Mariposa 2 is you can use it without actually the need of another biopsy. However, in lung cancer, we are, it is, I would say, one of the top cancers that we really used precision or personalized medicine. So maybe in the future, we'll have a better understanding in terms of who is the perfect fit for a Mariposa 2.
Yeah. So moving to kind of tolerability, because you have mentioned there are a number of discontinuation rate. Maybe I recall 8% on the on the AMI chemo, but I was wondering, is that discontinuation rate on the chemo part or amivantamab part or both? Is there any kind of details on the discontinuation? What was the reason? And it's part of the drug, part of the regimen, or whole?
Yeah, if we look at actually the discontinuation, when we look at the chemotherapy arm, it was actually 4. And then if we look at the amivantamab chemo, 11, and then 14. And this is, they said, of all agents due to adverse event. So they did not specify what was the cause of their discontinuation of the treatment.
Yeah,
But
because
we
yeah,
we
go
have to
ahead.
admit that more, like if we add more medication, it will come at cost of toxicity. Initially, we did have a concern about the infusion-related reaction. However, by educating the patient, by also educating the nursing, Dr. Lehabi was mentioning he didn't have any infusion-related reaction. I have another patient also. It was one of the issues. So I think a proactive approach in terms of managing the toxicity is really important to try to manage and decrease these numbers.
Yeah, yeah, definitely. So I think that's probably the justifications, and I understand that the more treatment or the more combo, the more toxicity. But I assume that the chemo part have large contribution in those toxicity, as well as the discontinuation rate that may be related to that as well. About also the brain, which I think the brain mets is something remarkable when it comes to this trial, because seeing that the combo really work in the brain mets, and I do agree that brain mets is one of the issues that we have in EGFR mutant, and especially in the second line, because most of those patients, they do fail in the brain mets, though osimertinib is one of those drugs that really have high CNS penetration. But the question is, given the fact that they do have kind of CNS activity, are we deal with the combo the way we deal with osimertinib, where we could delay the radiation? For example, if someone with brain mets and post osimertinib, are we doing the same with TKI, where we could delay the radiation, or the data with combo is not enough to push for that direction?
It's a difficult question because, I guess not all brain mets are the same. If the patient is really symptomatic and you're concerned about these brain metastases, then maybe close monitoring and try to use the target, and if no response, to consider radiation therapy. However, again, we don't have enough data. We'll learn with time. The interesting about Mariposa 2, if we compare the quadruple versus the triplet, it was very impressive intracranial hazard ratio for the amivantamab chemo. So do we really need lazertinib? This is another question.
Yeah, I agree, because I was assuming that the brain mets response mostly linked to lazertinib, because I thought that this is CNS penetrant. But when you see the curves, you doubt that you need lazertinib, because the response is been there even with the chemo amivantamab. I think that's really interesting finding, and that's really the most, I would say, the most impressive part with that interim analysis is the survival, which though it's trending, but I would say it's more kind of significant. And I can see the hazard ratio did not cross 1. I don't know why it's trending not positive, but it's quite significant that we do see clear or trending for survival in a second line setting, and that's probably will explain what we are coming through in the coming year when we have this in more kind of frontline setting. Any thought about why survival might be significant or trending in this trial in particular? What's really the culprit in that finding?
Yeah, I think I'm just trying to think, could be actually trying to target multiple pathways. So targeting the MET, the EGFR, and then adding the chemotherapy, maybe it has something to do with this. It is interesting, and I guess as with what we saw with Mariposa 1, I guess with time the trial will show an impressive overall survival data. You know, the other challenge that I think is if we start to use Mariposa 1 in the first line setting, then where will be the role of Mariposa 2 in the second line? I guess maybe now we have patients on osimertinib, but in future, if we are using Mariposa 1, then where to use Mariposa 2? This is another question. For the Mariposa 2, we do have concerns about the toxicity profile yet. I think we should, it is changing practice because it is showing a survival data, and also we can manage the toxicity profile if we are seeing an overall survival benefit. You know what I mean?
Yeah, I do agree, and I think one of the other concern, which I believe will be something solved in the future, is the IV, the infusion reaction, and I do understand the sub-Q might be the best way, and that's, I would say, will push more to use amivantamab in first line setting, because you will go the treatment with just sub-Q and oral, and I think that's will be more kind of impressive and convenient way to deliver the treatment. And this is the way things started when it comes to EGFR. We were using chemotherapy, then we were moved to oral therapy, with first erlotinib, gefitinib, and then osimertinib. So the beauty of treating those driver mutation is to avoid chemotherapy, and this is what we're doing for the last 10 years and more than 10 years now. And out of sudden we went back to chemotherapy when we have used the Flora. And I think that's a setback in the treatment of oncogenic driven tumor. And I think we should back on the track to try to avoid chemotherapy, or at least delaying chemotherapy. I think this is one of the important concepts, and in the near future. Thank you, Dr. Samah. I think it's thank you, Dr. Mirfat. So thank you so much for that. I'm not sure if you have any question before we close.
Thank you very much. I think you covered very well, and Dr. Samah as well with the discussion, and it was excellent as usual, Dr. Samah, and thank you very much for responding to all the questions. And I think it's like you both pointed out, it's a learning era, and I think we have an option so far, and it's a good option as well. And with that, I would like to thank all speakers tonight, Dr. Ahmed Al-Lahibi, Dr. Samah, Dr. Walid Selwi, Prof. Khouri, and thank you, Dr. Abdullah, for chairing the Satellite Symposium and enlighten the session as well with your discussion. I would like to thank Prof. Qattan for supporting, and I would like to thank Johnson Company for sponsoring this tumor board tonight. And last but not least, I would like to thank all the attendees, and thank you very much for sharing with your cases and asking opinion. It's really something totally appreciated. And last but not least, the organizing company, Event Group, Ms. Wafa, and Dr. Muhammad Abdul Wahab and Mr. Rami. Thank you very much all for your effort and care and excellent opinion. And see you next month, inshallah. Thank you very much and have a good night. Thank you.
Thank you.